All right, so for this presentation, I'm going to be talking about the knee, some of the related structures around it. Okay, so the knee is a pretty complex joint, even though it mainly just does flexion and extension. Okay, that little hinge that happens there. It relies a lot on the stability on the ligaments, on the joint capsule, and a lot of the surrounding musculature. Okay, it's designed to weight bear. Okay, and it's one of your main joints for motion. Okay, the tibia bears a good amount of weight. Okay, that's your lower leg bone. Okay, the fibula. Okay, that's another one of your lower leg bones, but it's more on the lateral side. Bears about 10 to 15% of the weight. So the articulations. Okay, your femur. Okay, one of the hardest bones of your body. Okay, your thigh bone, if you will, articulates with your tibia. Okay, your patella, your kneecap. Okay, it's a sesamoid bone. Articulates only with your femur. Okay, so there's a floating bone that sits in there. And then your tibia and your fibula articulate together. Okay, your fibula does not articulate your femur at all. Okay, just know that. Right here, bone-wise, okay, is your femur. Okay, tibia, your big shin bone right here, and your fibula, as you see this smaller bone here on the outside. Okay, you can see the articulation of the tibia and the fibula together. Okay, on the femur and the patella. Okay, so the patella is a sesamoid bone. As I said previously, it's encased within the patella tendon. It does help out with kind of making a better lever. Okay, is what the prime goal of it. If you put your knee straight and you relax the muscle, you can actually wiggle your patella side to side a decent amount. Your patella does not, when you bend and extend, it does not go just straight up and down. Okay, because it does do a little bit of motion. Okay, it does more of this kind of like crescent moon shape. Okay, as you bend and extend your knee, and if you kind of watch it and you feel it, you can see it kind of like when you bend it, it kind of like makes this little motion out here. Okay, at this angle. Okay. Let's see. Over here we have your tibial tuberosity. That kind of shin bone that sticks out there. So if you ever have like a lot of patella tendonitis or osgood schlatters, whatever it is, you usually have a pretty pronounced tibial tuberosity. Okay, it sticks out pretty far. That's where all your quad muscles attach to. We'll get to what your quad muscles are here in a minute. Okay, but it's a really, really important factor. Okay. Let's see other important things. Here's the head of the tibia. Okay, a nice flat area where the articulation of your femur kind of goes. Okay, it sits in a nice little notch, nice and flat. There is a little bit of rotation that does occur between the your femur and your tibia. It's called the screw-home mechanism. Okay, so as you fully extend and flex your knee, because of the condyles you see here, the lateral medial condyles, okay, doesn't fit almost perfectly. I mean, it looks really nice in here, but for that to clear this, you need, it's like very minute. I think it's between 5 to 10 degrees of external rotation to occur every time you extend your knee. And you never realize it happens, usually. It's very, very subtle, a very small amount. Just for these condyles to clear all these other kind of like fragments. Okay, so a little bit of external rotation does occur, but for the most part, your knee is primarily just a flexor and extensor. Okay, muscle-wise, okay, so your quadriceps, okay, femoris, okay, is the true name of your quads, okay, is made up of 4 muscles. You guys know that. And it's quad means 4. Okay. So you have your rectus femoris. Okay, that is a 2-joint muscle sitting up in there. Okay. Your vastus lateralis. Obviously, it's more lateral. Vastus medialis. Okay. Often called the VMO. Okay. Vastus medialis oblique. There's a little bit of an oblique section of your vastus medialis. A lot of people argue that there's no really such thing as an oblique. But for the most part, we just refer to it as the VMO for the most part. And then you have your vastus intermedialis, which is very deep underneath the rectus femoris. Okay, so those 4 muscles make up your quads. Hamstring-wise, okay, you have your biceps femoris. Okay, so biceps just means 2 heads. Okay, on the femur. You have your long and short head. Okay, those are very lateral. And then you have your semitendinosus and semimembranosus. Okay, so to break it down, semi like half or partial. Okay, it's half tendon, half membrane. Okay, and they kind of overlap each other for the most part. Okay, and those are a little bit more posterior and posterior medial. Okay, So those three muscles make up your hamstrings. Okay. You also have your adductor magnus, which is one of your adductor magnet muscles up in here. It does have a hamstring portion to it, so it does do some hip extension. Okay. So some people can argue that the adductor magnus is also a form of hamstring. Okay. You see up in here we have your gastrocnemius, your medial and lateral head. Okay, that is your calf muscle. Okay, so that does cross the knee joint and does help with knee flexion. Okay, as well as plantar flexion. Okay, over here, okay, this is the medial side. This is the lateral anterior view of the knee. Okay, we have your pes anserine. Okay, this is a very flat section. Your tibial tuberosity is right here. Okay, and your pes anserine is going to be this kind of flat area right here. Okay, so you have your sartorius, your gracilis, and your semitendinosus all attached right here. Okay, so if they're really tender, kind of right in this area, just medial of the tibial tuberosity, a lot of times you can suspect that, okay, my gracilis, which is like one of your primary groin muscles, is really tight or inflamed. Same with one of your hamstring muscles, and then sartorius, I'll talk about here in a minute, kind of this muscle kind of wraps around and has a lot of different functions. Okay. Here's another picture. Sorry, it's not the best, but it gives you a little bit wider view of your quadriceps. Okay, so here's your rectus femoris right here. Okay, now your rectus femoris is the only two joint muscle in your quads. Okay, because it also crosses the knee joint. Okay, and then your vastus lateralis. Okay, up in here, vastus medialis, vastus intermedialis. Okay, you see here with the rectus femoris exposed. Okay, here is the quadriceps tendon that you see here. Okay, which attaches to the patella, which attaches to the patella tendon, down to the tibial tuberosity. Okay, here's a really good picture. This is my favorite pictures of showing the lower leg. Okay, so again, rectus femoris, VMO, vastus lateralis. Okay, so here's that sartorius muscle. Okay, so it starts here in the front, it kind of goes and wraps around. So it does a lot of different muscle actions. It does hip flexion, hip external rotation, knee flexion. Excuse me. It does a lot of different things. And I believe it also assists in hip flexion as well. Or I said that previously, sorry. So that muscle kind of wraps around. It's not one of the quad muscles. Just know that. Okay, deep in here we have your adductors. Okay, pectineus does hip flexion and some adduction. Then your adductor longus, adductor magnus, and there's an adductor minimus that's deep in there. Okay. Here on the outside, okay, we have your tensor fasciae latae, okay, or your TFL. Okay, so that sits right where if you were to put your hands in your pockets, that's right where that muscle is. Okay, so that muscle, along with the gluteus maximus, attached to your IT band, which is a really long band that travels along the outside of the leg and does a lot of that lateral stability. It's a very thick, long band. It's super important. And a lot of time it gets really inflamed, especially with like runners. They'll get what's called runner's knee. I'll talk about that here towards the end of the PowerPoint, what that is. But that is a really kind of thick tendon. Okay. Here is a good picture of your hamstring group up in here. Okay. You see your biceps femoris here, and semitendinosus and semimembranosus muscles. Okay. Up in here, okay, we have your iliacus. Okay. And then your psoas major. Okay, so both of those muscles are very, very deep. Okay, your iliacus, that's actually inside of your hip. Okay, more on the posterior side of your pelvis, of your ilium. Okay. And then your psoas major. This muscle goes up and it actually attaches to the anterior surface of your spine, so very, very deep. Okay. They both come down and they form the iliopsoas muscle, which is your main, really super deep, massive hip flexor. Okay, so your two main hip flexor muscles are going to be your iliopsoas and your rectus femoris. Okay, those are your main hip flexor muscles. All right, postures. Okay, so postures. Okay, we're going to have genu valgum. Okay, so this is kind of a very subtle genu valgum, what people look like. So this is often called knock-kneed. Okay, so you have this kind of valgus force on the knee. Okay, genu varum, also called bow ligaments. Okay, and then genu recurvatum is more of a when they extend their knees, they can go past 0. Okay, some people can go pretty extravagant. These are, for the most part, pretty subtle. Most likely the common things you'll see. More so than this one. Occasionally we'll see this extreme genu valgum. Okay, genu varum you don't see too much of. Sometimes the genu recurvatum excuse me, can be pretty intense, or it's like coming up like this. I've seen a few people like that. Nothing that's wrong with them. It's just how they are. One of the good labs I like to do, given this is during COVID when I'm recording this, is I'll have my class kind of walk around and see how people walk. Kind of crazy to see how weird people are. Usually it's a lot of genu valgum. Okay, especially they have a lot of flat feet. The duck walk, the toes go out. Kind of a walk. Genu recurvatum is more of a standing posture. You're going to see that. Sometimes you'll see it when they walk. When their leg kind of shifts forward, their leg like almost hyperextends, and it looks kind of crazy sometimes. Some other issues with the genu valgum and genu varum is you see the spacing right here. I know the picture's not the best. I apologize. So with the genu valgum, you have a little bit of an opening more on that medial side where your meniscus is. Look at your meniscus here in the next few slides. Okay, there's more of a pinching more in the lateral side of meniscus because that space is not closed down. Okay, so this can contribute to a lot of different issues meniscal-wise for pain. And the opposite for genu valgum, okay, the winding of the lateral area and more of a constricting motion on the medial side of your meniscus, just that spacing. Also, ligament-wise, with genu valgum, your MCL, okay, your medial collateral ligament, again, we'll talk about it here in a minute, is also now on more of a, not really stretch, but it's under more strain as a result of this posture. Okay, same thing on the genu varum. It's going to be the lateral collateral ligament, or the LCL, which is going to be under more strain. All right, so more ligament-wide, some other structures. So this is your meniscus, okay, up in here. Okay, this is your medial meniscus, and this is your lateral meniscus. So this is kind of like that shock absorber of your knee. Okay. Here you have your patella just kind of reflected back so you can see all the other structures. Okay, on the inside, this is your medial collateral ligament. A lot of books will call it your tibial collateral ligament, okay, just because this is your tibia connecting to your femur. And then this one is your lateral collateral ligament or your fibular collateral ligament. Okay, this is all lateral. Also, to keep a note is on your MCL, where your MCL actually does attach to your medial meniscus. Okay, so if you suspect a really good MCL sprain, my bad. A really good MCL sprain, you can also affect the medial meniscus just because of the attachment site. Your MCL is also encased within the actual joint capsule of the knee. So it's very, very hard to kind of palpate that, where your LCL is not within the joint. Kind of sits outward, does not attach to the lateral meniscus at all. You see the gap there. Not injured very often. Okay, MCL is more injured just because of the forces that may come, contact sports, weird steps, whatever it is, where that force is coming from usually from the outside inward, that lateral and medial force. Okay, inside we have your ACL or your anterior cruciate ligament. Okay, and then behind that we have your posterior cruciate ligament. Or your PCL. Okay. Here's your tuberous tuberosity right here. Your pes anserine is going to be in this little flat area right here. Okay. Here's your fibular head. Okay. Head of your fibula. Okay. Kind of attaches down to your tibia right there. Let's see. All right. All right. Meniscus. So your meniscus is a cartilage. Okay. You have your medial lateral meniscus. Okay. You see here the anterior view, topical view, looking down at the meniscus. Okay, it forms like almost these like two C's. You have different layers of your meniscus. Okay, so the outer area is your red zone, and then you have a red-white zone in the middle, and then your white zone, white zone. Okay, a lot of people refer to this as just the red, pink, and white zones, and what that indicates is just blood flow. That's it. Okay, So the outer layers have more blood flow than obviously the white zone. Okay, and that varies a lot with injury. Because you have an injury in the white zone, it's not going to heal. Okay, it's rely on any of the nutrients within that synovial fluid to provide it with nutrients to heal, which takes a very, very long time versus any injury in the red zone heals substantially faster. Still slower than like a muscle or bone, but can heal depending on the tear. Okay, so meniscus function. Okay, so it increases the stability, and by deepening the plateau. Okay, decreases the friction by about 20%, and increases the contact area by about 70%. So as you put pressure, it kind of expands out. Okay. Okay, and it gives you more of that stability and support and that shock absorbing function. Okay. So it does absorb shock. A lot of times they will do a meniscectomy, which they will remove their meniscus, as a result of an injury or fraying or whatever it is. A lot of time they can still do normal activities. They will have a greater risk of arthritis down the road. Sometimes I'll go in and just like take out like a little section of it, or just take out all the fraying. Sometimes I'll have to go in and anchor it down, depending on the types of tears that occurs. And there's a lot of different types of tears. Okay. Usually with a meniscus, if they do an MRI, one X-ray is not going to show anything. It might just show fluid in the knee. So they might do an MRI. MRI is just going to show something's really wrong, but not really to the extent of it, until they actually go in and like, oh, you have a worse tear than we thought. Okay. So meniscal injuries. Okay. So you can see here's an example of a flap tear here. So it's a thickness tear there. Here's a bucket handle tear. So it's a tear all the way kind of round in the middle, and then that kind of tear, the inner section of that will kind of flop over. Okay, which causes a lot of joint line pain, a lot of pain while walking, and so forth. Most of the meniscal injuries is a result of compression and rotation that occurs. Remember I said a little bit of rotation that does occur in the knee. Also just rotation that happens when you're planning and pivoting. Okay, also very, very important. Or just on luckily random act of God that occurs in like I injured my meniscus when I was stepping out of a golf cart. Weird things that happen. Okay. Meniscal tears. A lot of time you'll have effusion, that's a swelling within the joint. Joint line pain, loss of motion. You have locking or clicking. Rare chances you'll have pain with squatting. Actually, you have a lot of pain with squatting, but you won't have like a lot of giving way. Okay, especially with the deep squats, you're especially going to get a lot of pain. Management, they're going to try every chance they can to save the meniscus. I talked about a little bit. They'll take meniscectomy. We'll take it out. The lack of blood flow really affects the healing times on meniscus injuries. I talked about the ligaments already on them. Again, here's your MCL. Okay. LCL, and then ACL and PCL. You see the ACL and PCL form an X. Okay, and they do a little bit different functions. Posterior side, you see how big this PCL is. Okay, so PCL is going to be bigger than the ACL. And then the MCL is significantly bigger than the LCL. All right, now we're talking a little bit about the other different, a little bit more in depth on the ligaments. Okay, so your MCL, okay, as again, attachments is the medial femoral condyle, okay, up in here. It does attach to the medial meniscus, okay, and then to the medial tibial plateau up in here. And the purpose of the MCL is one, support, and two, it resists valgus forces, which is that lateral to medial force. Now going to the LCL, okay, or the fibular collateral ligament. Okay, attachments are the lateral femoral condyle right in here, and then down to the fibular head. and that resists the varus forces, which is the medial to lateral, which you don't see too often. Okay, MCL injuries. Okay, usually the cause is a valgus force. Okay, usually pretty significant. Signs symptoms, it could be a complete loss of stability, minimum to moderate swelling. Okay, because a lot of it's going to be within the joint line. Immediate pain and aching, tender over the MCL, obviously, loss of motion, positive valgus stress test. Okay, so the stress test is you're just stressing the ligament. Usually you're going to put it just kind of in full extension, and you're going to put a valgus stress on it. I took all the special tests out of this PowerPoint just because that's a pretty advanced thing that I don't want to really teach you guys too early on. And so I've only seen 2 grade 3 tears. So grade 3 is a complete tear of the MCL, which usually the result in a surgery. Not all the time, because the MCL can repair itself, but a lot of times they will do a surgery to repair that if it's a complete tear. One time I remember on the MCL, it was a wrestling tournament, and if you wrestle, he was getting his leg ridden, and it just gave way. And I wasn't even looking at that mat at the time, and I was like 2 mats away, and I heard it pop. It sounded like a gun went off, and I knew exactly what it was. Okay, it's a very kind of distinct pop. It's really loud, and he had no pain because he tore any kind of nerves that are encased within the MCL that deal with something like that kinesthetic awareness. Okay, so he had pain initially, and it was gone. Okay, and then on the stress test, there was a deformity, so I could move that knee way more than I wanted to. For example, I can move it kind of like this. Instead of that going straight down like this, I can move the tibia in like that. And I stopped because I was like, I don't need to see anymore. LCL injuries, okay. Again, the varus force. You don't see too many of them just as a result, but sometimes you'll see the sprain. There'll be pain and tender over the LCL, swelling and effusion around the LCL, joint laxity on any kind of varus testing, and they could cause irritation to the peroneal nerve. So the peroneal nerve, and the nerve's going to wrap right around here. It goes right around kind of like the neck of the fibula. Okay, so an injury to the LCL here, okay, can just usually cause some kind of weird effect to that nerve. All right, the ACL, anterior cruciate ligament. Okay, you see here, they actually have it torn. Okay, once you probably see the PCL a little bit better. Okay, but this is the ACL right here. Okay, see the X I talked about. You can see a little bit of the X here, and it also makes an X here. Okay. So for the forces, okay, so that so the PCL is torn here, and then the ACL is torn this one. So the ACL goes here from like back to front. Okay. The ACL prevents that anterior translation of the tibia on the femur. Okay, so if this is my femur and this is my tibia, okay, and this is like this normal knee flexion, okay, that ACL prevents that tibia from sliding forward. Okay, so the ACL is the most studied ligament in the knee. Okay, obviously, prevents that anterior tibial translation of the tibia on the femur. Non-contact mechanism for ACL is around 80% of all tears. Okay, so 80, I say more, sort of 85% of all ACL tears are non-contact. That's all that means. Okay, symptoms: intense pain, usually, sometimes not. Loss of normal knee function, pain with movement, instability is going to be a big one. Heard or felt a pop. Females have a higher rate of ACL tears than males because they have wider hips. Okay, due to childbirth, and as a result of the wider hips, they have to have more hip control. Okay, as a result, and so just they naturally have this little bit more of a valgus, genu valgum on their knees as a result of those wider hips. And not all females have like the wide hips. Some have really narrow hips, but it's the wider hips that really result of that need for more control of your hips, which your hips control your knees as a result. So, like, if I was going back, I go back a lot. Sorry. Okay. For example, this maybe a female, just thrown out there, okay? Because the hips should be wider, and so if they were put her knees together, kind of like this, okay? They would have a little bit more because of the wider hips. It's going to have just a little bit more of this angle right here, which is normal for females over males. Okay, we're just the wider hip areas, and so it's going to need more control in the hip area down here to control your knees. But it also predisposes females a little bit more to the ACL tears just because they're now a little more so in this motion. Okay, so the most common mechanism of injury, okay, after is decelerating, okay, so that foot in contact with the ground near full knee extension, okay. There's a valgus force on the knee, okay. Quadricep contracts, produces a shearing, okay, anteriorly, and tibial internal rotation. Okay, this produces the most tension on the ACL. Okay, high chance of rupture. Can also be in combination with tibial external rotation, and this is the cutting motion. Just to break it down. Also known as knee forced hyperextension of the foot plantar. That's the other way of tearing your ACL. Okay, for this top one, that's just a cutting motion. You're just cutting. That's it. I had these two videos here. They're not the best videos. I'll probably find better ones. You can probably just YouTube better videos on ACL tears. There's also what's called the unhappy triad. And what an unhappy triad is, that is a tear of your MCL, your ACL, and your medial meniscus. Okay? A lot of times it goes hand in hand, especially with that cutting mechanism and that kind of giving way. Once the ACL goes and the MCL goes and the meniscus goes because of the attachment to the MCL. Okay? That's what an unhappy triad is. ACL factors. Okay, there's extrinsic and intrinsic factors. Okay, so the extrinsic factors are, for the most part, anything that we can control. Okay, the intrinsic are the physiological, psychological factors. You can't really, that's just kind of how you are, how you're born. You can't control it, just that's just how it is. Okay, so the extrinsic ones, okay, level of conditioning, skill, playing style. Okay, are you dangerous or not? Amount of preparation for practice and games. Okay, environmental considerations, and the type of equipment, like a knee brace, ankle brace, whatever it is. Okay, so the better skill you are, okay, your chance may increase a little bit, but usually you have more control, usually. Playing style, okay, are you more like a dangerous playing style or more safe? Amount of prep and practice, okay, how much have you trained for that kind of motion and activities? Environmental considerations, okay, slipping, that's usually the big one. Whether it's slipping, is the grass slipping or is your foot just slipping on the surface? Okay, or is it a fall that resulted in this? I mean, I know someone that tore their ACL kind of like tripping off their the hitch of their boat. Okay, kind of dripping off, their foot got caught, and that's what had did it. The intrinsic factors, okay, the femoral kind of notch size. Okay, so the notch, rare picture, okay. Here's this notch up in here, okay, the patellofemoral kind of groove. The ACL size, okay, how big is it? Okay, laxity. Some people are more lax on the ACL. Some people are really, really tight on it. Lower extremity anatomical malalignment. For example, Q angle, which is just like how they measure like the different angles of the knee. They have genital recurvatum, valgum, they have pronation, lower leg, increase external tibial torsion, All these factors can just, like, you can't do anything about it. It's just how they are. Okay, so that can also play a factor. Neuromuscular factors. Okay, so how efficient are your nerves and muscles? Okay. Do you have a lot of joint stiffness? Muscle activation patterns. Okay. Activation patterns is just how efficiently do your muscles and nerves, one, move, and usually your muscles contract at a proximal to distal area. Okay. For example, for like an ACL, okay, your hip muscles should all contract before your quads and lower leg muscles to control your knee. Okay. Just so you can get, because if it goes opposite, a lot of times it's not the best thing in the world. Okay. Strong quadriceps activation during eccentric contractions is very, very important. But that neuromuscular control is really, really important. Okay. Odd info, you do not need your ACL. Okay. It is not a needed ligament. It is important for stabilization, yes. And if you don't have it, you may have to do, like, let's say it's torn, you may have to have surgery down the road for some kind of arthritis or to redo it. You trying to see what else for it. Some people are born without ACLs. Okay, that does happen every once in a while. They have no issues. If let's say you tore it, a few physicians, like here in the Valley, they'll say, all right, if you increase your quad and hip strength and all your other surrounding musculature, you'll be fine. I've seen that happen. Okay, there's a higher chance of injuries to the meniscus. Sports may be difficult as a result. Your VMO upon injury to your ACL, like let's say tear or rupture of your ACL, atrophies very, very quickly, usually within days. You can visibly see that vastus medialis just kind of gets smaller. Okay, they really don't know why. It just kind of does. Your VMO is very important for stability and tracking of your patella, especially post ACL tear. It's pretty much one of the main muscles they do a lot of rehab on, but it's only really engaged during that last like 15 degrees of extension. Okay. So VMO hypertrophy, or building it up, is very difficult to achieve as a result. Okay, so recovery post-surgery of ACL is roughly about 2 years, but the times are 100%. Usually within that time, they can go back to activity, fine, but they're not going to be 100% until literally almost that 2-year mark. Okay, and the biggest thing with ACL is it's a very, very long recovery. That's it. Okay, you may have the surgery like within a week of injury if you get in pretty quick. But when they redo it, having that kind of bony plugs just takes a long time for your body to kind of take it over for you to get that optimal strength. Okay. So the recovery is a very, very long time. And that's the worst thing about the ACL surgeries, and it's just a recovery process. Okay. Because it takes 2 years really to get that strength back. After the first year, you can usually do most everything. And given there's no complications, side effects, whatever. But getting that full strength back, usually it's almost 2 years to the day. Prevention. I think I talked previously in other sections about preventive programs. So you can look these up on your own. You just Google them. These are all free programs. The FIFA 11 is a very common one with soccer, and that's really just kind of like a warm up and ACL preventative programs. The PEP is also a good one. It's probably like my favorite one. It's a bit more well-rounded. It's just a preventive injury and enhancement performance program. Okay, and then the peak control program. They're all very similar. All the exercises are the same, but they're pretty big documents because it tells you like how to do a warm up for like your team or yourself. Here's your structured like warm ups. How you do this and that. Different motions and you increase them over time, and it tells you however long it takes, and you should spread them out for. That way, there's a greatest reduction in ACL tears. Next one is the PCL, the posterior cruciate ligament. Okay, the PCL is larger than the ACL. Okay, it is the most important ligament in the knee. Okay, it is not. Excuse me. It does not get that much media attention because it's not really isn't really hurt much in athletics. Okay, it is the central axis for rotation. Okay, in your knee, provides 95% of the posterior tibial translation. Remember, the ACL was anterior tibial translation. This is posterior. Okay, so it's the femur, and this is the tibia. This is like knee flexion up in here. Okay, so it prevents your tibia from going backwards. Where your ACL prevented anterior translation, PCL prevented that one. Often known as the dashboard injury. Okay, because you're going to see this in auto accidents, to where they're sitting down. Okay, so they're in knee flexion like this, and then they get fender bender. Okay, they go forward. Their knee hits the dashboard. Okay, and it shifts their tibia posteriorly. That's usually how you're going to tear your PCL. The other ones you can see like equestrian, get kicked by a horse or land really, really bad. I've seen one in football. And it was the same mechanism as the dashboard injury, which I mentioned previously. Most at risk during a fall, forcing the knee in a hyperflexion with the foot plantar flexed. Is also the reason. Okay. Sign symptoms: instability, swelling posteriorly, kind of that popliteal fossa, the area behind the knee. Your pop, pain, that's pain, especially in the popliteal fossa, as I mentioned previously. Grade 1 and 2, and they won't do any surgery on it. Grade 3, sometimes they'll do surgery, but the outcomes are very, very poor. Okay, I think I read somewhere back in the day, so it might be a little old data, but the outcomes are like 25% for PCL. All right, next, IT band syndrome, iliotibial band syndrome. Okay, so here's a good picture of your IT band here. Okay, kind of in that white area. Okay, so pain is going to be roughly out here, that condyle area. So this is often called runner's knee. Okay, usually an overuse causes irritation of IT band from just a lot of friction of sliding. Because every time you bend your knee, that IT band is going to shift posteriorly. And you extend, it's going to shift anteriorly. So obviously runners with that light, heavy repetition exercise is just going to slide back and forth over the femoral condyle. Let me get a picture. Over this condyle right here. Okay, because IT band runs right down in here. Sorry. Here. This is medial, this is lateral. Yeah, it's going to run right down in here. And just that repetition of going over it just causes a lot of just kind of pain. Okay, a lot of discomfort, tenderness over that area, and that you get a lot of that clicking motion. Okay, so I have the TFL, the tensor fasciae lata, highlighted because that's a main muscle that's affected. That one and your gluteus maximus. Okay. So a lot of time if someone comes in for runner's knee, okay, I'm not going to do much down here. I'm going to focus up here. Okay, because a lot of time, 100% of the time that I've seen runner's knee, their TFL has been super, super engaged. And it's like knotted up. So I'm going to try and release the TFL, which I happen to know like a release for it, which helps out almost immediately. A lot of times, but you can foam roll it. That and the kind of gluteus maximus to kind of help with that. Back in the day, foam rolling, okay, you say, oh, your IT band hurts, okay, let's foam roll down here to kind of release it. You can't release your IT band, okay? It takes about like 3 tons of tension to kind of stretch out your IT band, so foam rolling is not going to do much. So, but because it's just a big tendon, okay, tendons don't stretch. Okay, so in case of that, let's attack the muscles that attach to it. Okay, so it's going to be usually the TFLs will be really inflamed because your TFL also assists in hip flexion, especially in those runners. They can just have a compensational issue of over activity of their TFL. Okay. Their gluteus maximus could not fire enough. Okay, so maybe some glute work. Okay, then maybe they're relying on their hamstrings for extension and not their glutes as much. Okay, so that could be another thing. So relax the TFL and maybe activate the gluteus maximus. Okay, so management. Okay, correct foot and leg length alignment. Sometimes that might be a few things like hips are off or whatever it is. Good warm-ups and stretching. Avoid activities that aggravate it, like running on incline really kind of gets it. NSAIDs, okay, non-steroidal anti-inflammatory drugs. Okay, Sure orthotics can help out a lot. I mentioned foam rolling, also really, really good. All right, patella tendonitis. Okay, here's a really common one. Okay, so mechanism is overuse, almost all the time. Okay, you're gonna have this area right here that's just really, really inflamed and painful. Usually, other mechanisms are poor jumping landing mechanics. Okay, usually it's the landing mechanics, not really jumping. People call it jumper's knee. It's really landing knee. So patella tendonitis is a repetitive microtrauma. Okay, you can have degenerative changes called patella tendinosis. Okay, biomechanical abnormalities, structural abnormalities, and a lot of tightness can contribute to this. Okay, so I'll look on like landing patterns. I'll look on muscle activation. I'll look on tightness of the quad, especially. That can contribute to the patella tendonitis. Symptoms: okay, pain on active movement, pain on passive stretch, loss of function, repeated overuse activities, running and jumping especially, pain on resistive movements, tenderness, and pain on knee extension. Okay. So for landing knee, lender's knee, let me see how badly I can do this activity in here. Okay, so basketball and volleyball are common ones. Okay, so when they're doing their sport, they jump up, they land very, very hard. Okay, as a result, when you land that hard, okay, or however how you jump up, okay, your tendon is taking all that force. Okay, so whether if you jump up and kind of land, okay, and you absorb the forces, your muscles are absorb the force, and they do a much better job at that force distribution than your tendons do. Okay, so that's really goes with the landing mechanics. Sometimes another thing that I mentioned in here is going to be the underactivation of your VMO, your vastus medialis oblique. Okay. So a lot of time, it's probably like 80-90% of the time when they come in for patella tendonitis, they're going to have pain mainly just on the medial border. Okay, so what happens is how the muscles pull on your patella, okay, again, you have 4 quad muscles, okay, the rectus femoris and the vastus intermedialis, okay, they pull straight up, okay, the vastus lateralis pulls more to the outside, laterally, and the vastus medialis pulls medially. Okay, so as a result of that, if one is, so when they all fire, your knee captures go pretty much like up and down, pretty normal. But a lot of time, people have poorly developed VMO. Okay, so as a result, the vastus lateralis takes over and it pulls your knee kind of almost in this direction. Okay, which gives you a lot of pain and tenderness on that medial border. Okay. So I'll also look at like how strong is their VMO. Okay, so when they extend their knee out strong, can you see it firing? Okay, you may have this like fully developed vastus lateralis. Okay, super developed, super defined on the outside, and nothing in here. Okay, so the first thing I do is I need to start building up this muscle. Okay, to counteract that. Stages of pain, 3 stages. So stage 1 is pain after activity. Stage 2 is pain during and after activity. Okay, and stage 3 is pain pretty much all the time, and then your performance is hampered in some way, usually because of pain. So measurement, okay, modalities, ice, phonophoresis and autophoresis. That's just the way of administering medications through the skin. Ultrasound, heat. I'm not going to heat the area that's inflamed too much. I'm more in maybe heat the muscles around it to kind of warm them up. Okay. Therapeutic exercises as needed. You can use a patella strap. Okay, as a patella strap, you can either do the homemade ones with like pre-wrap, or you can buy the over-the-counter ones. And that just more displaces the tension. Sometimes it works, sometimes it doesn't. You can do a friction massage. Okay, a very successful treatment. A lot of people like it because you got to take like a week off after doing it. So the deep transverse frictional massage. Okay, and the goal is to cause inflammation. Okay, so you cause this high amount of inflammation. You don't use lotion when you do this kind of massage. You just go kind of across the fibers of the knee, of the patella tendon, which goes downward, up and down. You just go across, really, really hard to kind of dig your thumbs in there to get really inflamed. The purpose of that is you're trying to start the healing process. It's really kind of get it going. It might just be kind of slowly kind of going, but this really just kind of gets it going. Okay. But then you got to stop pretty much all your other treatments because it's going to take a while for that thing to kind of start to heal. So you may got to take like a week off as a result of the friction massage. Next is chondromalacia patellae. Okay, this is a softening and a deterioration of the back side of the patella. Okay, so the patella makes contact with the femoral notch. Okay, it gets soft. It starts to kind of corrode. There's not a lot you can do for someone with this. The stages, there's like 3. Some people have 4 stages. First one's going to be swelling and softening of that kind of cartilage. Stage 2 is a kind of fissuring and softening of the cartilage. 3 is it starts to deform on that surface and actually cause some fragmentation. So you have all these little fragments that could potentially get in the joint line. No one knows what it caused. It kind of comes and goes. Usually when someone has it in one knee, it's in both. They suspect kind of abnormal patellofemoral tracking, external tibial torsion, foot pronation, femoral anteversion, patella alta, which is your kneecap rides up super high, shallow femoral grooves, laxity, are all possible things. Rest is not the best thing for this, and neither is a lot of activity. So you got to find that kind of happy medium in usually some kind of rehab for this. Signs and symptoms, okay, a lot of pain while walking, running, squatting, steps, etc. Pretty much a lot of motion with anything. Swelling around the patella. You can have a grating sensation every time you bend and extend your knee, which is super painful. Treatment's usually conservative. Avoid anything that aggravates it. Isometric activities. Meds. Neoprene sleeve to kind of keep it kind of warm. It kind of helps a little bit. Orthotic devices to correct any footwear, lower leg issues are usually the main thing. Sometimes they'll do surgery and they'll go in and on the backside of the patella where the chondromalacia is, they'll take a needle and they'll kind of like scrape it and cause it to bleed. Okay, and the bleeding, what that is just starting the healing process. That's all they're doing. By like poking it and causing it to bleed, they're just making it start to heal. Okay, kind of like the cross friction I mentioned previously. All right, epiphysitis injuries. Okay, so the epiphysitis injuries, okay, are areas usually on growth plates. Okay, epiphysitis. Okay, so the common ones, Osgood-Schlatter's. Okay, there's another one of Larsen-Johansson. Okay, same thing, they're just on different sides. Okay, so the Osgood-Schlatter's is the epiphysitis occurs at the tibial tuberosity, the tubercle, right here, where all your quads attached to. And then the Larsen-Johansson, okay, it just attaches. Is it just the same thing at the inferior pole of the patella, so the bottom section. Okay, both start in your adolescence. Okay, and so usually it's like Lander's knee, whatever it is. Okay, so epiphysitis is actually a bone injury. Okay, epiphysitis is classified as a fracture in a way. So it's that pulling off of that growth plate here in the tibial tuberosity. And usually after all that repetitive like trauma and stress or whatever the micro trauma is from like landing or growing too fast, whatever it is, it can actually pull that tibial tuberosity not really off, but it'll kind of raise it up from all the inflammation. So some of these people that have Osgood-Schlatters growing up, they have this huge tibial tuberosity. And that's just a result of the Osgood-Schlatters. Okay. The Larsen-Johansson just happens at the inferior pole of the patella. Not as common as Osgood-Schlatters. Okay. But it's all the same thing. And you actually grow out of it. Usually everything resolves by around your 18, give or take, because your growth plates close and they're stronger, and then you don't have the issue anymore. So just to compare them, okay, avulsion fracture of the tibial tubercle, okay, very similar. Larsen-Johansson is very similar, okay. A bony callus forms on the enlarged tuberosity as a result, okay. Same thing can occur at the inferior pole of the patella. Sorry, too many recordings today. They both usually resolve about 18 years old. Okay. Complete avulsion of the tibial tubercle is a major complication. Okay. So it can happen. You don't see it too often. That's just of where the tibial tuberosity is, that kind of pole I talk about, will come off completely. Very, very painful. What happens is the knee or the patella just kind of rolls up the thigh because nothing's holding it down. They're just screaming in pain. You can't really do a lot for them at the time. Very, very painful. And then for Larsen-Johansson, the excessive repeated strain on the patella tendon. Okay, same thing. Okay, so management, usually conservative. Decrease the activity, okay, until the epiphyseal union occurs. Okay, so sometimes 6 months to a year, okay, for that kind of union to occur, depending on how bad it is. They don't really cast anymore that I've seen. Maybe if they're like really young kids that keep them from really moving. Then more just kind of splint them. Ice pre and post activities promotes pain, kind of reduce that inflammation. Isometric strengthening of the quad and hamstring muscles. Also, what's really good is eccentric strengthening. Okay, that eccentric strengthening of the quads is really good for tendon development. Right. Next is patella dislocations and knee dislocations. Okay, so this is a patella dislocation. This is where the kneecap should be sitting here. In this case, it's more off to the side. It's always going to be lateral. Okay, so that's just patella. Versus a knee dislocation is the entire tibia is not aligned. For example, this is the tibial tuberosity right here. It should be over here. So with a knee dislocation, a true knee dislocation, that is a limb-threatening injury. They could potentially lose their limb because there's a high chance of, with a knee dislocation, some kind of cut, the blood flow is cut off to the lower leg. Versus the patella dislocation, just kind of painful. That's it. I'm going back. So the patella dislocation, you're just kind of tearing the kind of like connective tissue that keeps the patella kind of roughly in place. Okay. You shift to the side. Very painful. The knees always be bent. Don't try and put it back in unless you know what to do and trained and allowed to do it. Just call the ambulance. Let them deal with it. With a knee dislocation, make sure you call 911 and tell them, like, hey, I have a knee dislocation. And you can say, I don't have distal pulse, for example. Okay. Very, very important. And always splint it how it's found. All right, next, femoral fractures. Okay, so a femoral fracture is a life-threatening emergency. Okay. It's one of the few, appendicular bones that is a life-threatening emergency. Just as a result of the structures next to it. Okay, so there's a femur fracture here. Okay, so these lines here. Okay, so this is the femoral vein, femoral artery, and femoral nerve. They all run right next to, just medial to that femoral, to the femur bone. Okay, so let's say you have the fracture here, and it gets displaced, like it is here. So usually as a result of any injury, you have what's called muscle guarding. And that's just the muscles surrounding that bone constrict to kind of protect itself so it doesn't move. So all these muscles are contracting to protect itself, but there's no stabilization for this to occur because now the main stabilization structure, which is your femur, is now shattered. So these sharp edges that you see here are going to go and just kind of just slice through the femoral nerve, artery, and vein. Okay, so your femoral artery is like as big as your pinky. If not a little bigger, it's a pretty massive artery. And just severing that will, given it's not a compound fracture, okay, so the bone is not out through the skin. Okay, this is all internal I'm talking about right now. Just severing that artery, you will lose about 500 cc's of blood, okay, because that's as much as that leg, that thigh can contain, which is enough to put you into shock and kill you. Okay. So what a lot of EMS and fire crews carry is traction splits. Now, back in the day when I went through it, it was a Sager and O'Hare were the common ones, but there's a few other ones now. So these splints go up on your upper thigh, one attaches up there, and one attaches down at your ankle. And then what it does is it kind of pulls the bones apart. Okay, so someone with a femur fracture, screaming in agony. It's one of the worst painful injuries in the world. Okay, but you just going up there and sticking your foot in their crotch and yanking on their leg is immediate relief of pain. Okay, for a lot of these. I wouldn't do it unless you really know what you're doing for that, because once you pull traction, you can't let go. I had a buddy that there was sheriff search and rescue up in the hills, and this is like 10, 15 years ago. And they picked up a hiker that had a femur fracture, and he had to hold traction for an hour and a half while I load him up in the helicopter ride all the way to one of the hospitals here. He had to take the next 2 days off because he couldn't feel his arms afterwards. Because it's not like a light traction. Like, you have to oppose all the thigh muscles contracting. Okay, so it's like holding like 150 pounds probably and just throwing it out there for an hour and a half. Okay, very, very difficult. I mentioned this about the blood loss, extreme pain, usually a deformity present, obviously 911. Think about CPR once you see this. Traction splints. If you have a femur fracture, see what else is wrong, because usually there's other things that could potentially be wrong, whether it's obvious or not. Next one, I'm going to talk a little bit about some of the tests for ACL. Not that I want you to do them, but I just want to mention them briefly so you can kind of see them if you're ever shadowing someone or you see what it actually looks like. So this is just an anterior drawer test. So this one and the Lachman's here are very, very similar. So you're going to have the knee bent about 9 degrees, them laying down, their back, and you're just trying to elicit laxity and or pain. Okay, so you're sitting here, your hands are behind, and you're going to pull anteriorly on the tibia, and you're trying to looking for, I believe it's more than 7 millimeters of displacement. You'll see, like the knee comes around here, when this person pulls anteriorly on the tibia, it's good. You'll see this kind of step off, because you're gonna pull the tibia an inch sometimes out, okay, when you shouldn't. Okay, the Lachman's is another test for the ACL, but instead of having the full knee flexion, it's about 20 to 30 degrees of flexion, so just a little bit. The upsides of this, I like the Lachman's better than anterior drawer, because a lot of times, okay, so you're trying to pull anteriorly, the hamstrings a lot of time guarding as well as other leg muscles. So that guarding, okay, if a hamstring is contracting, you can't pull forward because your hamstrings are opposing you. Okay, and you're supposed to feel, make sure that they're relaxed. Sometimes it's very difficult for the person to relax. That's why I like the Lachman's better, because you just need a little bit of knee flexion. The other reason is a lot of times after someone tears their ACL, they don't want to bend their knee this far because that hurts. Okay, so you just need a little bit right here, which is usually more of a comfortable position because they don't want their knee fully straight, but just kind of elevated. So those are the two main ones. There's another one called the Lilly test, okay, or the lever sign, which I'll put a this video here in the module. It's a pretty cool thing. It's by the actual guy that made it. So the test is no older than like 20 years old. It's a fairly new test. It only tests for complete rupture. Okay. So you can watch it. He actually does part of the surgery. You can watch a little bit part of the surgery. And he is from Italy. You can see like how he does it and everything about it. And there's like a translator for it. It's a really, really kind of cool video. How he shows just like a functional one finger. Okay, shows a negative test, and a positive test. He put all his forces jumping on this leg, and it's not moving at all. Okay, so it's a very cool video to watch. I suggest checking that out. And that is it for the knee.